Okay, let us start the lecture, that is kidney stone. I'll be more focusing on the diagnosis part and treatment part, and the basics of the stone disease I have already explained in my previous video. So please refer to that video for the basics. So kidney is the most common site of stone formation, as we know that, and the common age group is around 30 to 50 years. And I've already told you that regarding etiology, pathogenesis, and types of renal stone, please refer to my introduction to urolithiasis lecture. Okay. See, for the diagnosis, obviously the patient will come to you with some symptoms, and we examine to find the signs. Okay. So the symptoms, the most common symptoms is pain, and the size of stone does not correlate with the severity of pain. That means a smaller stone can produce severe pain, whereas a large stone like staghorn stone may not produce the severe pain. They just present to you with the mild discomfort. Hematuria is also a very common, common symptom, and it is associated with the pain. Fever and nausea, vomiting, these are also sometimes found. Okay, as I've already told you, sometimes the stone are very silent. They stay in the kidney for years and years, and patient may not have a symptoms. And always, when you suspect a patient having a kidney stone, ask them about the past history of kidney stone, and ask about if they have done any stone analysis. Because see, any recurrent stone, we have to think not only about the treatment but also for the recurrence, and also search for the risk factor like the BMI, like the dietary habit they eat, asks about the family history, positive or not, and asks about if there's any known metabolic disorder, and also some chronic disorder like diabetes. These all factors are preventable. We can prevent this, or we can control this disease such that it prevent the recurrence of stone. Now let us discuss about the pain related to kidney stone. Pain usually occurs at the back or the flank area or the loin area, and the pain is usually dull in nature. Sometimes it is very severe. So severe pain due to the kidney stone is known as renal colic. Okay, see, the pain usually depends on the site. Okay, if it is in the calyceal system or in the pelvis, the pain is basically due to the distension of renal capsule. That's why it is dull in nature. If it is at the PUJ region near the upper ureter, the severe contraction of the muscles of these area can produce a severe colicky pain, which is known as renal colic. Okay, and the pain radiate towards the umbilicus anteriorly, or it may go to the testicle or labia majora due to similar nerve supply, that is T10 to T12. I'll explain later on in the picture. And the pain is aggravated by jumping movement. Okay, and relieved by rest and medication. It's very obvious whenever the pain moves, whenever the stone moves, it causes pain, and pain is associated with nausea and vomiting if it is severe in nature. So you should know the causes of flank pain, or you can say the back pain or the loin pain. See, if you see a pain along the right side, see, there are so many causes of pain along the flank, or the back or the loin area. These are some common pain I'm just describing. Let us see how to remember these causes. Okay, if you remember the basic anatomy where the location of the organ, then it will be easy for you to remember. See, so here we have a kidney in the back area. Okay, gallbladder is related to over here. So obviously when there is a flank pain playing on this area, or the back loin pain, we'll think about the kidney. And the most common causes of painful kidney are stone, okay, hydronephrosis, or pyelonephritis or UTI. These are the most common causes of pain in the kidney. And see, And the flank area or the back, our body contains a lot of muscle. So sometimes the stretching of the overstretching of the muscles can produce a pain that mimic the loin pain. And sometimes the gallstone, okay, the radiation of the gallstone pain or the deep pain in the gallstone sometimes get confused with the stone in the uh, kidney. So these are the causes of a flank pain or the back pain that may get confused with the kidney stone. If you see a left side, then left side is similar thing. Okay, first you should understand what the organ that we have along the left side. So see, obviously the same kidney causes like stone in the kidney, hydronephrosis means dilatation of pelvic ulcer system leading to stretching of the kidney, or infection in the kidney UTI. They all causes pain along the left flank or the left loin area. And we know along the epigastrium and along the left area, there we have stomach, and also we have a pancreas deep line. So the pain of pancreatitis or the pain of the peptic ulcer disease may be felt along the left upper abdomen, and that can be confused with the kidney stone. And obviously body contains a lot of muscles along the flank or the back which can be stretched and can mimic the pain along the pain similar to the kidney stone. These are some differential diagnoses that will help us to differentiate the different type of pain. So you have to remember this cause. These are not only the cause. There are a lot of causes. I've just given you the common cause. Okay, let us see this picture. This right side, this picture is from the back. You can see these are the vertebra. Let us draw line, and this is a 12th rib. So this angle is known as uh, renal angle. So most of the time the patient will have pain at this angle. Okay, kidney will be lying over here like that. Okay, if there is a stone inside the kidney, patient will feel pain along the back area, or you can say flank area along the renal angle, and the pain may radiate anteriorly towards the umbilicus, or sometimes it can be felt anteriorly below to the testicle or labia, because the the kidney is supplied by T10 to T12 sympathetic nerve supply, and the umbilical area is also supplied by T10, and the testicular area is also supplied by T10. Due to similar segmental supply, the patient can feel the pain of the kidney along the anterior abdomen, along the umbilicus, or maybe towards the testicle or labia. So this is the basis behind the radiation of the pain related to kidney stone. Okay, hematuria. So see, whenever there is a stone in the kidney, the stone moves around, and once the stone moves around, it lead to some trauma, and that lead to hematuria. Hematuria means bleeding, right, in the urine. So the hematuria is painful. Don't forget that, because the stone is the cause of painful hematuria. And it is gross. Gross means the patient can usually see the blood mixed urine, and total means the blood is mixed with the urine in such a way that it become red from the beginning of the micturition to the end of micturition. That's why we say it's a total hematuria. Intermittent means it is not a regular continuous. Sometimes there will be hematuria, there won't be hematuria for the some period. So these all the four characteristics. If you, sorry for the interruption. Okay, if all these four characteristics are found, then we can say this is the hematuria related to stone. Okay, intermittent, painful, gross, and total type of hematuria. Sometime patient may not see the bleeding, but you can identify in the microscopic examination of urine routine examination. And sometimes the old clotted blood can come out as a very dark color urine, just like a tea colored urine. These are sometime thing. Okay, most of the time, the hematuria is painful, gross, total, and intermittent in nature. Remember this thing. Fever is not a regular thing. So whenever there is a obstruction of a of a urine flow by the stone in kidney, it may lead to infection. So obviously, the stone along the pelvic calyceal junction, this pelvis and the ureter over here, if it is obstructing the flow of urine, then there will be stasis of urine, and stasis may lead to infection. And when there is infection of a kidney, it is known as acute pyelonephritis. And don't get confused with pyonephrosis. Pyonephrosis means accumulation of the pus inside the kidney. That is, whenever there is a obstruction, it leads to hydronephrosis. Hydronephrosis leads to infection. That is now known as pyonephrosis. So, how to recognize? Basically, the patient will present to you with acute back pain or loin pain, very severe pain, associated with high degree fever, high fever with chills and rigor, and feature of septicemia sometime. That means septicemia means what I'm talking about is if a patient has a high fever, chills and rigor, severe acute pain in the back, and hypotension and tachycardia, this is usually suspicious of urosepsis or infection leading to the shock. Okay. So whenever you suspect a patient having a stone and they produce this type of picture, this is always regarded as the urological emergency. So the patient of a stone disease with a feature of infection if it is obstructed, then it is regarded as urological emergency. We have to do something immediately to relieve the obstruction. Sign is not found, but yes, we can find the tenderness or pain along the renal angle. This is the vertebral line. You can see this may be the 12th rib. This is the this is the renal angle. We have to palpate by a thumb, and patient may say he has a pain or she has a pain whenever you palpate this area. Okay, this is known as renal angle tenderness. If the kidney is obstructed by a stone, suppose, okay, obstructed by a stone, then it lead to hydronephrosis. And the hydronephrosis, if there's a hydronephrosis or pyonephrosis, then you can palpate the kidney. Otherwise, normally stone, inside the kidney cannot be palpated. And always, whenever you suspect the patient having a stone disease in kidney, always watch for the sign of infection, that is, fever, tachycardia. And if there is hypotension, then it may indicate patient may have a septic shock. So always check for the vitals, temperature, pulse, blood pressure. All those things are very important because sometimes the kidney stone may be associated with infection or septic shock. These are the things that we take care of while we examine the patient. So whenever we suspect a patient having a kidney stone, how to suspect? They will usually come to you with a feature of painful hematuria. Most commonly, they will come to you as a painful hematuria, and the pain radiate along the umbilicus or downward towards the testicle, and may be associated with nausea and vomiting. And on examination, you may find patient having a renal angle tenderness. So this will be the clinical scenario. So after getting these clinical scenario, we have to investigate. So during investigation, so see, usually what we can do is we can do this first for investigation. Okay, at once we give at once urine routine culture, renal function test, plain X-ray QB, and ultrasonogram QB region. Okay, and after getting the report, we'll almost know there is a stone in the kidney. After getting that, we can either do IVU or we can do non-contrast CT scan to get a detailed information regarding the kidney stone. Okay, this is the one way of doing investigation. The other way is what we can do is you can do a urine routine fine, renal function test fine, and you can directly do CT scan, non-contrast CT scan, excluding these tests. We can do that as well. So either you go for urine routine culture, renal function test, plain X-ray QB, and ultrasonogram, and these all investigation will help you to diagnose the kidney stone. And after that, you can go for IVU or CT scan, or you can follow other pathway that I have already told you. Okay, you can do that. IVU or CT scan. We don't do both. one is okay. CT scan is the gold standard. If you do that, CT scan is the best. See, I've already explained regarding the investigation. I'll be just focusing in short. We will then, there are a lot of things we do in the urine routine and culture. I'll be just focusing the important point. Pus cell stones are related with the infection. You know how the stone can cause infection, infection can cause a stone. That's why you always try to find infection, and the pus cell more than 6 per high power field are usually indicating the, I'm saying usually, not always, usually indicating the infection. And as hematuria is usually associated with the kidney stone, we can see RBC under microscope. And the pH is always important. As I have already told you, some stone are produced in acidic pH, other are produced in alkaline pH, and the knowledge of pH is required for the management as well. We can alter the pH of a urine such that to prevent the stone formation. Crystals, please remember the name of this shape of crystals, usually asked in exam, so you have to remember for the exam point of view, otherwise it's fine. Culture is always done, see, because I've already told you stone are related to the infection. So for the treatment point of view, even for the intervention, we want urine to be sterile. That's why infection should be eradicated before. Most of the time we have to stop the infection before surgical procedure. That's why cultures are routinely done such that we can see if there is any infection, and if there is some bacterial infection, we can give a appropriate antibiotics. So these are some shapes of the crystals. Okay, just remember those things. And regarding kidney function test, obviously any kidney disease, we do kidney function test. There are so many other kidney function tests. Basically we do serum creatinine, blood urea nitrogen, and electrolyte. These are very commonly done tests. By using the formula and the serum creatinine, we can identify the GFR as well. Estimated GFR we can calculate. I've already explained this thing in my previous slide, so just previous lecture. So just please follow that lecture. Regarding DTP renogram, we don't do DTP renogram that often. We do sometime when we need, sometime when we have to decide whether to save the kidney or not. Sometimes it is very crucial to decide, should we remove the stone or we should remove the stone along with the kidney. Okay, that is simple nephrectomy. In that scenario, we need a DTP renogram to know the exact function of the kidney. I'll show you later on when to do DTP renogram. I have the example for you. So routinely do creatinine, urea nitrogen, and blood urea nitrogen, and electrolyte. Okay, and DTP renogram is sometime done for the management purpose. So see, this is the X-ray QB. 90% of the stone are radiopaque in kidney. Okay, so so most of the time we can see the stone, radiopaque stone. See in this picture, what you can see. This is the sacral vertebra, left sacrum here. Okay, so this is lumbar 5, lumbar 4, lumbar third. So we have a radiopaque shadow at the lumbar third vertebra along the right side. Okay, this is the radiopaque shadow. So you can see, and I can guess this might be the stone in the kidney. So I'm saying might be, I don't know, because I cannot see the shape of the kidney. So to confirm, we have to do other investigations, right? So the another investigation we can do is ultrasonogram. Let us see other picture. Can we get another image of an X-ray QB? See, this is an X-ray QB. You can see over here. Okay, it will come. Okay, fine. X-ray QB. What you can see over here is a multiple branching radiopaque shadow extending from the lumbar 1 to lumbar 4 vertebra here in the both side. Okay, both side, huge one. So this picture, multiple branching radiopaque shadow, this is the case of bilateral diagonal stone. So we can identify this type of stone in plain X-ray QB as well. So you may get a very small stone in one side, you may get a stone in double side, you may get a stone, multiple stone in one kidney, you may get a branching stone in both kidney or one kidney. You can see lot of thing in plain X-ray QB. Now let us go for an ultrasonogram of QB region. See, ultrasonogram is a very excellent imaging technique, because it is very, reliable. It is very inexpensive, and you don't have any radiation. And the stone are seen as a bright ecogenic structure, producing the posterior shadow. You can see over here. I will show you first. This is the bright structure producing the black shadow. Okay, so this is the stone. This in this image, the kidney outline can't be seen that well. Might be due to the very big, large branching stone. Let me explain in the lower image. First of all, let us identify the outline of kidney. Okay, this is the outline of kidney, and this is the corticomedullary area, cortical area. You can see cortex is very good. You can see there is a bright ecogenic structure over here producing black shadow. So this is what a stone inside the pelvis. And you may say, what is this then? This also look like white. Though it look like white, it is not producing any shadow. So this is not a stone. This is normal fat in that area, and we cannot see any black area in the center. That is, it is not hydronephrotic. So the ultrasonogram is not only for seeing the stone, but it can give you a lot of idea. Number one, you can see the cortical thickness is very very important. You can see the hydronephrosis. There is no hydronephrosis over here, and so these extra information we can obtain from the ultrasonogram of the QEB region. And also, ultrasonogram is a very good test to differentiate. It can also show you not only the radio opaque stone, but also radio lucent stone. So that's why it is good. Okay, it's a very good test. Fine. So now, after this test, we will know there is a stone in the kidney. Okay. So now what to do? Do we need to do other tests? Yes, because till now we have just known the size of the stone, the related any abnormality in the kidney, and so on. But for the detail anatomy or detail planning, we need further information, which can be obtained by the IVU or CT scan. CT scan is the best than IVU, but still we can do IVU. Okay, so IVU here I have already explained what is IVU. IVU, what we can see is we can see the size of stone. We can locate the stone. Location is very important for the management, and even we can see whether there is any hydronephrosis. Okay, and the very good thing is it can show us the function of kidney as well. So these are the very important information that we can get. Let us see in this picture, if I view what you can see over here. The upper one, this one is a control film. You can see the faint radiopaque shadow here in the right renal area, and this image below maybe of 25 to 30 minute film. Okay, suppose here what you can see, the same radiopaque shadow that we have seen in the upper image correspond to the the calyx, the lower calyx, and the pelvis of the kidney. Okay, so in this scenario, what we can plan is so how to manage. Okay, I'll tell you later on. Let's see. See, the calyceal system is not dilated. It is normal. You can see the ureter is, the dye is going down, and the opposite side, what we can see is we can see the calyceal system is very good. Okay, not dilated, and even we can see the ureter, the dye is going to the ureter. So see here, the both kidney are functioning, excreting well. There is no hydronephrosis. Okay, these extra information we get. Now regarding the management, as this stone is very large, okay, must be more than 2.5 3 centimeter stone. So the larger stone in the lower calyx or the pelvis, the best option would be for this one is PCNL. PCNL. You can go from the lower calyx. If not, if there is no such provision of PCNL, no machine like that, then you can go for a direct open surgery, like a open nephrolithotomy. You can do that. Okay. So what I mean to say is, by knowing the size, the location, and the condition of kidney, we can plan for the management. And whenever you want to do IVU, please check for the contraindication. The contraindication are whenever the serum creatinine is more than 1.5 milligram per deciliter, don't do it. It can further damage the kidney. If the patient has a history of allergy to contrast, don't do IVU. It can further damage the kidney, as well as can cause the anaphylactic shock. Pregnant lady don't do it because we push dye, and that can be hazardous to the baby, or the multiple x-rays that we do during IVU can cause radiation hazard. Okay, so these should be avoided in these three scenario. Yeah, you can see over there. Now let us see one more IVU here. See, this is the control film of eye view where you can see in the lumbar third area, 5, 4. This is the way how we count it. Okay. So there is this radiopaque shadow, and this radiopaque shadow correspond mainly to the pelvis of the kidney. I'm just showing you the right half and slightly in the lower calyx. Okay, and the size maybe around less than 2 centimeter, around 1.5 2 centimeter. So for this patient, what we can do is, as it is in the mainly in the pelvis and the calyceal system, what you can do, you can go for from below and do RIRS. Okay, you can do that, or even you can try for the PCNL or mini PCNL. Okay, you can do that. So see, by knowing the size, by knowing the location, by knowing these informations, we can plan the surgery for this patient. Let us see another eye view. See, there is a in the control film in the A, you can see there is a fairly large radiopaque shadow present at the left renal region at the level of 3 2 lumbar second lumbar third vertebrae. Okay, so now let us follow the sequence of eye view. We take a lot of X in the eye view. Okay, so in the 5 minute film, what we can see in the right side, the calyces are seen. Okay, easily seen. The pelvis are seen. Even dye is seen inside the ureter. We can do that. See that. Okay, so this is good. Right side. But left side, what we can see here is the outline of kidney. You can see somewhat, and still we can see the radiopaque shadow, but we cannot see. Sorry, but we cannot see the the contrast in the calyceal system, or not even in the ureter. So after 30 minutes, you can see over here in the right side, you can see all the calyceal system, you can see the pelvis, you can even trace the ureter down, and you can see the bladder. But in the left side, still we cannot see anything going down to the ureter, no calyceal system seen. Okay, and even after 2 hours, the late film, same thing is seen, we cannot see anything. So this case is a typical case. Okay, where you can see this might have happened due to the situation like this one. Suppose patient had a stone. Okay, mainly obstructing the PUJ for a long time, that led to the hydronephrosis. This is hydronephrosis. Okay, and due to chronic hydronephrosis, the kidney cortex might have been damaged, and due to this one the dye is not excreting. So what we can see from this image in the eye view is, this is non excreting kidney. So that non excretion may be due to non functioning. Okay, so how to know that? So in that scenario, what you can do here is, you can do DTPA renogram now. Okay, to know the function of kidney. And after knowing the function of kidney, if it is more than 10 percentage, you can save the kidney. If it is less than 10 percentage, we can sacrifice the kidney along with the stone. So we can do simple nephrectomy. So see, by seeing the IVU, we can even see whether it is excreting or non-excreting, and we can decide what to do further and how to manage this situation. Okay, CT scan abdomen or KUB. Non-contrast CT scan is a gold standard or ideal for the stone diagnosis. Okay, and also for the management of the stone. So see, this not only show you the stone, it can show you both radiopaque and radiolucent stone, but also it can differentiate the different cause of pain. Okay, for example, suppose patient might have acute pain due to the pancreatitis, as I already told you, due to the other causes. So it can show you the exact cause, because CT scan can not only show you the ultrasonogram, sorry, it not only show you the image of the kidney, but also it can show you the surrounding image as well. So it is very good to differentiate other cause of the pain in the abdominal area. And beside that, this is very good investigation, because it can locate exactly the stone. It can show you the size of stone, and it can show you the density. Density means it is measured in Hounsfield unit. If the density is more than 1000 Hounsfield unit, then it is regarded as a hard stone. Okay, so some technique that we break the stone cannot be applied. Mainly, we cannot apply ESWL if the density is more than 1000 Hounsfield unit. Okay, skin to stone distance. Okay, suppose this is the CT scan, and this is the kidney, and this is the stone. So the distance from the skin to stone, that is skin stone distance, if it is more than 10 centimeter, then the patient is regarded as obese. And in this obesity, due to the increased distance due to the fat, the shock wave cannot be effective for the breakdown of stone. So see, the management can be planned by seeing this extra information of a stone, like density, skin to stone distance. These are very important for choosing the different type of management modality for the stone. As I've already told you, this can also diagnose the loosened stone. And as this is a non-contrast CT scan, we are not using any contrast media. Here, what we can do is safely we can investigate for the patient having a kidney damage or kidney impairment. It have some disadvantages, because it has more radiation hazard in compared to IVU, and also it cannot tell us about the functional status of kidney, because we are not using any dye. That's why sometimes we need to do a contrast enhanced CT scan, mainly whenever we have to deal with a very complex anatomical kidney like duplex kidney. In that scenario, we have to do contrast enhanced CT scan. Otherwise, most of the time non-contrast CT scan is enough to plan for the surgery and for the diagnosis of the disease. Let us see some CT scan image. See, this is the actual view of CT scan. I'm talking about the left side. Always, to know whether it's a contrast or non-contrast, see the aorta first. Aorta is gray. See the kidney parenchyma. This is gray. Okay. Whenever kidney parenchyma and aorta is gray, then this is IV contrast was not given in this case. So whenever it is a non-contrast CT scan, the white structure if you see inside the organ, it is always stone or calcification. You can see bilateral hyperdense or white structure at the pelvis of the kidney. Okay. Similarly, this is the right image here. This is the see the aorta. Aorta is gray in color, and see the parenchyma is also gray in color. So this is a non-contrast CT scan, and here the white structure or hypertensive structure inside the kidney in the left side. So there's a this one is a bilateral renal stone in the pelvis. This one is a left kidney stone or left renal stone. We can easily see, and see so many organs we can see, right? See, we can not only locate the stone, but we can see other organ as well. So this is very important. CT scan is very good in that aspect. So fine. So now, then how to treat the kidney stone? The treatment can be divided into various options like conservative management, emergency management, surgical management, and prevention of recurrence of stone. We can classify in these four headings. Let us discuss one by one. Conservative management. Basically, conservative management means observation. So see, stone having a size less than 0.4 centimeter can pass spontaneously, and the size between zero point 0.4 to zero point 0.6 centimeter, only 50% stone of the kidney can pass downward. So we advise the patient to take a lot of water, adequate amount of water, and we advise them to do a jumping exercise, okay, skipping, and we give them some analgesia, because once the stone move, it can cause pain. If there is severe pain, then we can ask for the IM pethidine or parectal or IM diclofenac. Always before giving the diclofenac or NSAID, check for the serum creatinine. It should not be given if it is impaired. In the less severe pain, that oral diclofenac is okay, fine. NSAID is better if the patient don't have the renal impairment. If renal impairment, you can choose other oral like tramadol, something you can do to give that. Okay, and observation should be abandoned, should be stopped if patient develop any signs of sepsis, fever, high fever, chills and rigor, because whenever the stone moves, sometimes it go downward in the ureter and can obstruct the flow, and the obstruction can lead to infection. So we have to advise the patient, if there is any sign of fever or severe pain that cannot be controlled by the analgesics, please come to us. We have to do something else. Okay, that is observative management is not applicable in that scenario. Emergency management. Sometimes the kidney stone can present to us as an emergency. Okay, how? Whenever the kidney is obstructed, and that obstruction led to infection or anuria, means decrease or lack of urine production. Okay, in that scenario, it is an emergency. How it happens? Suppose this is the kidney. Okay, stone has obstructed the Pews area, suppose at this area, then obviously that may lead to the hydronephrosis, can lead to stasis, and can lead to infection. So infected kidney, hydronephrotic infected kidney, having a high fever, this need a immediate management to relieve the obstruction. Or sometime the both kidney can be obstructed. Okay, or patient having a single kidney can get obstructed, such that the patient will have no urine or very severely reduced urine production. This is known as anuria. Both scenarios are regarded as urological emergency. We have to do something immediately. Okay, and that management is decompression. Urgent decompression is required. Decompress it, allow the urine to pass, and treat the patient later on. Decompression can be done by a stent placement, known as disease stenting, or what we can do is, under the ultrasonogram guidance, what we can do is we can put a tube inside. Okay, tube inside, and this is collected in the bag. Okay, urine is collected in the bag. This is known as PCN tube. PCN means percutaneous nephrostomy tube. This we can put inside and fix it over here, such that urine will come out. In the both scenario, what we have done is we have bypassed the stone, and we have allowed the urine to flow. After that, add some antibiotic and analgesics. When everything is settled down, then what we can do is we can plan for the surgical management. So this has to be done to save the patient life and to save the kidney as well. So this emergency management is either done by the disease stenting, or stent placed from the below, from the bladder, or we can do the PCN, that is puncture of the kidney and putting the tube, PCN tube, that is percutaneous nephrostomy tube. In both scenario, what we are doing is we are bypassing the stone, and the management of the stone will be done later on. Surgical management. So surgical management, again, there are various type of surgical management. Okay, let us see what are the indications of surgery. Whenever the stone is large and symptomatic, that means smaller stones less than 6 millimeter or 0.6 centimeter, which are not that much symptomatic, we just ask them to have a conservative management. Okay, smaller stone, not creating any problem in the kidney, we just ask them to have observation and have some exercise, jumping movement, take a lot of water, the stone may pass. But if the stone is large or producing symptoms, then it has to be operated. Any stone in the kidney with associated infection, in this scenario, we have to do the surgery. Okay, if our conservative management fails and patients start to develop pain and symptoms, then we have to go for a surgery. Obviously, patient having a kidney stone, and if the creatinine is increasing, then we have to do the surgery to prevent the further renal damage. Obviously, if the patient have a some anomalies like PUG obstruction and have a stone, then we have to do surgery to treat both stone as well as PUG obstruction. PUG obstruction means this one. See here. So this is the kidney. Okay. This is a congenital narrowing of the junction of the this is pelvis, this is ureter. The junction of the pelvis and ureter may be sometimes congenitally narrow, such that it won't allow the urine adequate urine to pass down. Okay, so it may lead to stasis. Stasis lead to stone formation. So if a patient have a stone as well as PUG obstruction, so two pathology, stone here, okay, stone, and PUG obstruction. If they have both pathology, then we have to operate, and we have to deal with the both pathology. If you just remove the stone, then the patient will have stone again. So in this scenario, when patient have a double pathology, we have to do surgery to treat both pathology. These are some indications for the surgical intervention for the renal stone. Now, what are the methods for the management? Okay, the method can be divided as minimal invasive surgery, which include ESWL, extracorporeal shock wave lithotripsy, percutaneous nephrolithotomy (PCNL), or retrograde intrarenal surgery (RARS). I'll explain this in detail. Wait. And also some open surgery can be done like pyelolithotomy or extended pyelolithotomy, nephrectomy, or sometimes we have to do nephrectomy partial or total or simple nephrectomy. We have to do that. So these these methods I will discuss one by one, and I'll teach you how to choose which method. Okay. So these are the options for the management of the kidney stone. Minimal invasive. Minimal invasive means we do some minimal technique like in ESWL we just pass a shock wave, not giving any incision to the body. PCNL RRS we PCNL we puncture the body. RRS we use a natural orifice urethra. These are all minimal intervention to the body such that patient won't have that much pain or that much it takes less time to recover. Open means we just cut the abdomen and go inside and do the surgery. Okay, old technique. Minimal invasive technique. So this is the treatment of choice nowadays. Most of the surgeons follow minimal invasive technique, and which type of surgery to follow, it depends on so many factors. Stone location, where is the stone, size of stone in the kidney, and stone composition, how hard the stone is, and associated any anomalies, kidney anomalies. So we have to take in consideration of all these factors before treating the kidney stone. So let us have some guidelines. Okay, these are summary of the guidelines. Okay, I've used Campbell Urology and the European Association guidelines. So see, whenever the size is more than 2 centimeter, that is a larger stone, and the hard stone, that is whenever the hardness is more than 1000 Hounsfield unit, which is measured by CT scan, then PCNL is the answer. Okay, large and hard stone. Okay, large means size more than 2. Some books says 2.5, you follow 2 centimeter. Okay, 2 centimeter. And hardness, if the hardness is more than 1000 Hounsfield unit, then we always do PCNL. And if other minimal invasive technique fail, like failure of RARS, failure of ESWL, we can do PCNL as a rescue procedure. So PCNL, these are the guidelines for PCNL. RARS, we can do up to the size 1 to 2 centimeter, and obviously for the lower calcium stone we can do that. ESWL, we can do up to 2 centimeter, but we don't do ESWL if it is more than 1 centimeter in the lower calyx. Okay, let me explain. Okay, see over here. If the stone is in the lower calyx, okay, the size should be less than 1 centimeter. If the stone in the upper calyx or the mid calyx or in the pelvis, we can treat up to 2 centimeter, up to, okay, up to 2 centimeter. But there are other factor as well. If there is an obstruction in the lower part, distal obstruction, then we cannot do ESWL, because in ESWL we just break the stone into small fragments, and that fragment will come out by itself. So if there is any obstruction in the distal part, we cannot do ESWL. And one more thing, if the stone is hard, more than 1000 ounce per unit, we cannot do ESWL. And one more thing I have told you, if the distance between the skin and the stone is more than 10 centimeter, skin stone distance, we cannot do ESWL. So these are some contraindications we cannot do ESWL. So PCNL, large and hard stones, and when other technique fails, RAS in between stones, okay. ESWL can be done up to 2 centimeter, but lower calyx stone we cannot do if it's more than 1 centimeter, because if we do more than 1 centimeter, then the fragment of stone will stay here in the lower calyx. It is difficult to come down, okay, because lower calyx is a dependent part. It is a very, dependent part. So if you break the bigger stone, stone will stay here. It is difficult to come out, okay. That's why we don't do that. So see, this is ESWL. It's a very just a picture to explain you. Detail later on I have for you guys. So patient is lying just under the machine. The machine will produce the shock wave. The shock wave will go down into the body, and it will disintegrate the stones into smaller fragments, and the smaller fragments will come out spontaneously by itself. This is what ESWL mean. Extracorporeal shock wave. Extracorporeal means the shock wave was produced outside the body, and then it passed through the body, focused into the stone inside the kidney, and break down into fragments that come out through the urine. This is what ESWL. Very basic I am talking now. Later on I will discuss in detail. PCNL, what we do, we puncture the kidney, go inside, break the stone into fragments. Here we take out the stone as much as possible. Few stone can go down, but we take out the stones out. So this is what PCNL means, percutaneous nephrolithotomy. Sorry, where I was here, right? Okay, some problem. Yeah. So this is another technique known as RARS. Suppose there is a stone in the kidney. Here what we do, we use a flexible ureteroscope, and from the urethra we go inside the bladder. From bladder we'll go inside the ureter and reach near the stone in the kidney and break the stone into fragments, okay. And we use a holmium laser to break this stone. After breaking, we can take out the stones, or we can fragment it very fine dusting we can do, which can come out spontaneously. We put a stent, okay, to facilitate. So we can do that as well. So this is what RARS means. We use a laser source of energy to break the stone into very fine fragments, and so fine that it can easily come out. We just make it like a dust. Open surgery. Open surgery, in today's time, open surgery, the indication is very limited nowadays, okay. Mostly we follow the minimal invasive technique to do surgery for most of the stone, but still we have some indications for open surgery. when all the minimal invasive technique fails, or when you don't have all those minimal invasive techniques, then you can go for open surgery. And when there is a stone associated with some anomalies, like PUJ, I have already explained, then we can go for open surgery, and we can cut the PUJ, and before repairing we can remove the stone and and repair the PUJ obstruction. We can do that. Okay, so same setting, single opening surgery. Okay, suppose here is a stone and here is a narrowing PUJ. So you can cut the narrow part, remove the narrow part, take out the stone, stitch the remaining part, repair later on, such that you have managed both, case, that is stone as well as PUJ. You can do that in open surgery. And the large, very complex stone like stag on stone, we can do open surgery. Also, other smaller stone where the minimal invasive technique fails, or the lack of minimal invasive surgery, we can go for open surgery. So if the stone is in the pelvis, okay, kidney pelvis, then we do pyelolithotomy. The name implies pyelo means renal pelvis. Okay, so if the stone is in the renal pelvis, here suppose, so what we do, we open the abdomen. After opening the abdomen, we reach the pelvis, we cut the pelvis, and we remove the stone. This is known as pyelolithotomy. Sometime what happen is the stone may be some branching, okay, branching stone maybe going inside the calyceal part. Then what we can do is we can extend the incision, up to the lower calyx, and make a big incision and take out the stone. This is known as extended pyelolithotomy. Okay, suppose suppose wait, let me draw the picture again. Suppose, okay, stone is in let me draw it well. Okay, suppose stone is in here in the calyx, inside the calyx. Okay, something like this. So by cutting the pelvis, it is very difficult to go inside and bring the stone out. So what we can do is we can cut the kidney radially, okay, and remove the stone. This is known as nephrolithotomy. And sometimes the stone is so branching in nature, you have to do very special type of surgery known as anatrophic nephrolithotomy. Okay, a big branching stone covering the calyceal and the pelvis area, known as stag on stone. In that scenario, what you can do is you can do a special surgery known as anatrophic nephrolithotomy. I'll explain later on, to remove this big stone. So see, still we have some investigation, some indications for the open surgery. So we can do this surgery. Okay, so when to do partial nephrectomy and when to do simple nephrectomy. So partial nephrectomy, when we do is, suppose a patient have a stone here in the lower calyx, here, big stone over here, and it has already damaged the lower pole. Okay, in that scenario, what we can do is we can sacrifice this area, that is lower polar area, and we can do partial nephrectomy, and remaining kidney can be stitched. Okay, we can do that. Or sometime when the kidney is damaged by the stone, especially it happens in the stag on stone, big stone staying inside the kidney for a long time and damaging the kidney. Okay, in that scenario, what we can do is we have to check the function of kidney, and the function is if less than 10 percentage, we can do that by DT radiogram. And if it is less than 10 percentage, then we can remove the stone and kidney at the same setting. It is known as simple nephrectomy. Though the name is simple, it is not simple. We say simple because we compare the process with a radical nephrectomy that we do for the RCC, that is renal cancer. So we say simple in that sense. Otherwise, simple nephrectomy is not that simple. Okay, so whenever it is damaged, then we can do that as well. We can remove the stone, kidney, and some ureter along with this all these three structure, and remove the kidney. So the damaged kidney, the non-functioning kidney, if you keep that kidney there, the problem is that kidney can get repeatedly infected, and that can damage the remaining normal kidney. That's why non-functioning kidney we don't keep, because we want to prevent the damage to normal other kidney. So see, this is the picture what we can see over here is pyelolithotomy. Here you can see the U7 incision was given to the pelvis, okay, and this should be at least 1 centimeter above the junction to prevent the tear. And you retract the upper lip, lower lip, you can see stone has been removed, okay. If you extend this incision towards the lower lip, to the lower calyx, then it is known as extended pyelolithotomy, which is done usually for the branching staghorn stone, like incomplete staghorn stone. You can do that. This is what anatrophic nephrolithotomy means. Anatrophism means lack of blood supply. Okay, what we do is whenever there is a very branching big staghorn stone, we cannot approach from the pelvis. We approach to the kidney. Okay, kidney has a vascular plane known as a Broddel's line, which lies along the lateral surface or slightly posteriorly over here in this area. Okay, see this picture, you can see. So what we do is, we know there is a blood supply of kidney, right? There is a renal artery, we know that. So the renal artery, most of the time, sometimes renal vein also, they are clamped for a while. Okay, before clamping, what we do is we put lot of ice around the kidney such that we decrease the temperature. If the temperature is decreased, the metabolic demand will be decreased. So after decreasing the temperature by putting ice slush around the kidney, we put a clamp. Once you put a clamp, we can open the kidney along the Broddel's line, and remove the stone. See, they remove the stone by the forceps, and repair the calyx and repair the kidney. Repair the calyx and repair the kidney, and you come out. Okay, before that you put a DJ stent. So, and you have to remove the clamp. So this surgery has to be done within 20 to 30 minutes. Okay, so as we have decreased the temperature of the kidney, the metabolic demand is so less, the kidney can withstand the ischemia for this much time. So as the name implies, anatrophic means we have decreased the blood supply for a certain period of time, and we open the kidney and remove the stone. This is known as anatrophic nephrolithotomy, usually applicable for staghorn stone. Now the question arises, sorry, arise how to treat the bilateral stone. What is the principle for treatment of bilateral kidney stone? If the patient comes to you with a stone in the both sides, what to do? So we have to think a lot of things. Okay, so always try to treat the better functioning kidney first. That if you know the kidney function, we can know the kidney function by various technique. The eye view can give you idea about the excretion of kidney. The thickness or thinness of the cortex of a kidney can be seen in the ultrasonogram, or accurate you can see by the DTP radiogram. So whenever you see the function, always if the both kidney has a stone, then preserve the better kidney first than the damaged kidney, because we want to preserve the better kidney first. So the answer is better functioning kidney should be operated first, remove the stone, then you do surgery for the other kidney. And question may arise, if both kidney has a similar function, then what to do? Then answer is obstructed kidney should be removed first. So whenever the stone is obstructing the flow, remove that obstruction. You may say, okay, fine, there is no obstruction, both kidney are functioning similarly, and we have the stone in the kidney. What to do? Symptomatic kidney should be removed, stones should be removed first. That means these three criteria. Number one, better functioning kidney should be first removed, the stone should be removed. Okay, if the both kidney have a similar function, then the obstruction, if there is any obstruction to the kidney by stone, that has to be removed first. and you say if both kidney have no obstruction, both kidney have a similar function, what to do? Then remove the stone from the kidney which is producing more symptom. If a patient say I have a more pain on the right side, then do the surgery on the right side. So these are some guidelines to choose which kidney should be operated first. Now the question may be arise, then what to do about staghorn? Staghorn is a very multiple branching stone. What to do? Okay, what to do about staghorn stone? Staghorn is the stone that is very comparable to the multiple branching pattern of horn in the deer. So that's why it is known as staghorn stone. So it may be complete staghorn, it may be incomplete staghorn. Complete means whenever there is a stone occupying entire pelvis as well as all the three calyces, then it is known as complete staghorn. Okay, staghorn stone occupying the all the callus, okay, and also the pelvis, then it is known as complete staghorn stone. And if it is occupying one or two calyces and the pelvis, then it is known as incomplete staghorn stone. So whatever the staghorn stone is, whenever there is a staghorn stone, now the question is what to do. It is very complicated thing, surgery. So still we can do some minimal invasive technique for this type of surgery, okay, stone disease. That is, we can do PCNL, ESWL, PCNL sequence. First we go and break some of the stone, okay, and then again the second setting we do a ESWL, break it in small pieces, then again we can go for a PCNL. We can do that. So we can do for PCNL, ESWL, PCNL, we can do that. Or what we can do is multi-setting PCNL or multi-puncture PCNL. That means what we can do is puncture the one calyx, okay, then break the stone, bring it out, and we can again go for the another puncture and remove it out. If not, then puncture one calyx, remove the stone that you can remove. Then again in next setting you do again another puncture and remove the stone. So multi-setting PCNL or multi-puncture PCNL can be done. Because I've already told you, now we want to do a surgery in a minimal invasive technique. But if it is not possible, then our old technique is there. You can go for an atrophic nephrectomy. I have told you, we can go for an extended pyelothotomy. You can do it, or if it is non-functional, you can go for a simple nephrectomy. So multiple branching stone can be managed by these techniques. Okay, remember this. These are very important thing. Now the very important thing. Okay, we know all the surgical procedure, the guidelines, everything. Now let us see, is there any way to prevent the recurrence? Yes, we can try for preventing the recurrence of stone, and this is very important. Okay, just treating surgically is not enough. You have to do something for the prevention. So there are some guidelines to follow for the prevention of recurrence. First of all, it is start after the removal of stone, not before that. Okay, once you remove the stone by any means, then you have to give the stone for the stone analysis. Stone analysis is done by the lab either by X-ray diffraction technique or infrared spectroscopic technique. They do that, and that means you have to do stone analysis for each and every patient. Okay, and for selective patient, high risk patient, we have to go for metabolic analysis, like patient having a recurrent stone formation, patient having a positive family history, or patient having a stone like a cystine stone, no, or patient having a single kidney. In those scenario, in that scenario, you have to always do the metabolic analysis. You know how to do it. I have already told you in my previous lecture. Please follow that lecture. How to do metabolic analysis, you will know there. Okay, I'm not going to revise. So after doing a stone analysis and metabolic analysis, you gave this for the lab. So what to do is we have two guidelines, two way. First is general guidelines applicable for each and every patient. We give this guideline to each and every patient, and there are some specific guidelines that is for specific type of stones. Okay, let us see the guidelines. See, regarding the fluid intake, okay, fluid, we know that whenever we take a adequate amount of fluid, it prevents the supersaturation of a urine. And you know, supersaturation is one of the most common factor for stone formation. So supersaturation of a stone can be prevented by adequate drinking of water or liquid. Then what is adequate? Usually around 2.5 to 3 liter per day. And and that fluid, that water, must produce at around 2 to 2.5 liter of urine per day. Okay, and the color of urine should be white, not dark yellow, should be white. And also we have to encourage the patient to take a water during the meal and 2 hours after the meal, because 2 hours after the meal there is a relative dehydration, such that it may promote the stone formation. That's why we have to say that please drink water at least every 2 hour. Okay, and we have to encourage the patient to take water before bed. This is only for the patient who have stone, okay, not for everyone. So you have to take the water before bed, such that the patient will wake up at the night and pass the urine. Why it is important? Because if the patient lie in the bed for hours and hours without waking up, then the stasis of urine promote the stone formation. That's why we want the patient to wake up, and when they wake up they go and pass the urine, and again they will take some water. Okay, and and always encourage them to drink some fluid containing lemon or lemonade. These contain citric acid, and you know the citric acid is important for prevention of the stone formation. And always avoid the alcohol, beer, soda, like Coke and Fanta, all those things, wine, because they contain a lot of oxalate and they promote the stone formation. In the past they used to say, even the textbook used to promote the beer, because it is a mild diuretic. It can help to pass urine, and it can help to pass the stone, but it is not true nowadays. We don't recommend, because it increases the chance of stone formation. Okay, remember these things regarding the fluid. And regarding the diet should be balanced diet. Okay, balanced diet. And the uh, those who are stone former, those patients should take, uh, they should not take a lot of protein. The protein should be restricted to 1 gram per kg per day. If the patient is 70 kg, then at least 70 gram per day, not more than that, because it enhances the uric acid production and oxalic acid production, leading to hyperuricosuriia and oxaluria. That is, it promotes the stone formation. And we have to limit the sodium chloride intake. Normal salt, okay, table salt, should not be taken more than 5 gram per day, because if this sodium chloride increase the crystallization of the calcium salt in urine, and that can promote the stone formation as well. We have to promote the food containing a lot of vegetables and fibers. And regarding the calcium, the calcium can be taken in normal amount, around 1 gram per day. And you should not restrict all the dairy product. You should not do that, because if you restrict the calcium, the problem is restriction of calcium enhances the oxalate stone formation, so that should not be done. And those who have to take a calcium supplement, they can take a calcium supplement, but that has to be within the range. And the stone friendly calcium supplement is calcium citrate. Okay, that formulation is better to take. And regarding oxalate, okay, so oxalate is found in various food, especially with all the vegetables. They contain oxalate. Spinach, chocolate, beetroot, tea, they contain high amount of oxalate. So we do not restrict oxalate to all the patients. Those patients who have oxalate stone, we can restrict, okay, but still moderate amount of oxalate containing food is okay. And regarding vitamin C can be converted to oxalic acid. That's why excess intake of vitamin C more than 2 gram per day is prohibited. It can cause the oxalate stone formation. Regarding the lifestyle, see, BMI, the obesity is the one of the key factor for the stone formation. We know that. So the BMI should be less than 30 kg per meter square. That is the level that above that it increases the chance of stone formation. And the patient should do adequate diet, adequate exercise, okay. And there's a nowadays there's a keto diet. We have heard a lot of thing about keto diet: high protein, high carb, high fat, high protein diet. These are not recommended for the patient who have stone disease because they promote stone formation. So these are some general guidelines for the patient having a stone disease. So these guidelines should be followed by each and every patient, such that it prevents the stone formation. Now, what are the specific guidelines? Specific guidelines are for the specific stones. Okay, for example, as I have already told you, a lot of stones, almost all stones are formed in acidic environment except struvite. So those patients who have oxalate stone, cystine stone, uric acid stone, for those patients, if you can convert the pH into alkaline, then this stone can be prevented for the recurrence, because once the pH is changed to alkaline by a drug or potassium citrate, then the crystallization of the stone is not possible. pH is very crucial for the crystallization. Okay, but for the struvite, we don't do alkaline urine, because struvite is formed at alkaline urine. So we have to change it in acidic. How to change that? We can give ammonium chloride to convert the pH of urine alkaline to acidic. Okay, the other drugs can also be used to make a urine alkaline, like sodium bicarbonate, 1,6 sodium lactate. We can use that, but most commonly we use potassium citrate. Okay, so you can use this potassium citrate, oral potassium citrate, for a lot of stones. Allopurinol and febuxostat, these are the drug which we use specifically for the uric acid stone. These drug, what they do is they prevent the formation of uric acid from xanthine. Okay, they stop the enzyme known as xanthine oxidase and prevent the conversion of xanthine to uric acid, such that there's a lack of uric acid in the urine, and the stone will be formed less. For, for the cystine stone, which is not that much common stone, we can use a thiola or penicillamine. What does they do is they combine with these crystal of cystine and make it more soluble and help to excrete through the urine. Okay, this drug can be used for cystine stone. Thiazide diuretics is used for the hypercalciuria, where there is excessive calcium. Whenever we use the thiazide diuretics, what they do is they decrease the urinary calcium excretion and prevent the calcium stone formation. In the struvite stone, if it is not if the struvite stone is not controlled by the antibiotic and the sodium chloride, then what we can do, we can add acetohydroxamic acid. This drug do is they prevent they inhibit the urease enzyme and prevent the stone formation. These are a bit higher level stuff. If you can remember these things, this will be mm, helpful for you later on. But at least you should remember regarding the general guidelines. And one drug, potassium citrate, which can be used for prevention of all type of stone except struvite. These things are the very general things. Other drugs and how they work, if you can remember, it is good. Okay, I think we have finished the stone part, but let me discuss some of the operative surgeries, some of the minimal invasive technique that we commonly do. Okay, number one is ESWL. So see, what we do in ESWL is the shockwave is produced outside the body. Okay, and that passes through the body to fragment the stone. So see the steps, what we do. See the picture in the right side. So we localize the stone first. Okay, we can localize the stone by using a fluoroscopy, X-ray or ultrasonogram. Here you can see the monitor. It has, see the stone over here. It has localized the stone. Once localization, what we do is we apply the gel. Usually the gel is maybe the gel that we use for the ultrasonogram, that gel at the entry point. So when you apply the gel at the entry point, now this machine, which is very focused, okay, this machine will produce a shock wave. Okay, This machine will produce a shock wave exactly at the point where we have targeted. Once it produces the shock wave will go inside and exactly at the focused point and start breaking the stone into fragments. So this shock wave can be produced by various machines, but nowadays we use a piezoelectric technique where the ceramic plates vibrate to produce a shock wave. So piezoelectric shock wave are commonly used nowadays. So the first step is to localize the stone by a fluoroscopy or ultrasonogram. After localization, we apply the ultrasono, gel. This technique is known as coupling technique. Okay, coupling means to apply the gel area at the gel at the entry point, and the shock wave that is produced by the machine, usually we use nowadays piezoelectric shock wave that passes through the body and fragment the stone. After fragmentation, the stone will go down by itself. We don't use any other technique. Sometimes we use medication to help, but mostly the stone go by itself. So see, once the shockwave into the stone gets shattered into pieces and slowly break down into smaller pieces. Okay, and they go down spontaneously. And we will advise the patient that in the next few days or week, the stone will pass gradually, and we encourage them to take a lot of water and NSAID if pain. Okay, so we give that thing to the patient and advise, don't worry, there will be some mild pain, there will be some bleeding, but if it is excessive then come to us. Otherwise mild pain, mild bleeding will be there, and we advise them to take a lot of water, and we advise them to have a painkiller if there is a pain. Okay, so see, indication, as I already told you, that the stone, if it is up to 2 centimeter, up to in upper calyx, mid calyx, in the renal pelvis, we can do. Stone should be less than 1 centimeter if it is in lower calyx. These are the indications we know. I'm talking about the kidney stone. ESWL can be done for the ureteric stone. ESWL can be done for the bladder stone. That I'll discuss later on. I'm just discussing about the kidney stone now. Complications. Okay, complications, obviously, see, whenever the we break the stone in the kidney and let it go by itself. Okay, then while it go down, while the fragment of stone go down, it cause pain. So you have to say that to patient, there will be pain, no problem, just take this analgesic or painkiller. If there's a pain, then you can have it. If pain is so severe that cannot be controlled by analgesics, then come to us. Hematuria, you have to say there will be some mild hematuria due to the acute slight renal damage or the movement of stone. But if the hematuria is severe, is not stopping and causing severe pain, then you have to come. Otherwise, minor hematuria will go within 1 week. uh, Renal trauma, yeah, when a shockwave passes, it can cause minor renal trauma, which is okay, no problem. This very interesting one is stenostresy or street of stone. That means what happens is whenever the stone try to pass down, sometimes the larger stone may get obstructed and other smaller stone will follow the path. Okay, like that. So in X-ray, what you can see, a lot of stone lying one after another. It looks like a stone passage or path of stone, so known as stenostresy. If it is, then what we do is either we can break the leading stone by outside ESWL, or we can go from lower, that is URS, and can break this stone and allow the other stone to pass. Okay, we can do that. Okay, fine. So see, in the past when we used to use the other type of the shockwave machine, that has some long-term complications like hypertension or CKD. But nowadays we use this piezoelectric type of machine, so the hypertension or CKD or chronic damage is not associated. not associated. And the hard stone, okay, the hard stone. See, one more thing, contraindication. So, as I've already told you, the large stone size more than 2 centimeter or more than 1 centimeter in the lower calyx we don't do. The hard stone like more than 1000 Hounsfield unit, like stone like brucite, cystine, calcium oxide monohydrate, not the dihydrate. These are harder stone which we cannot break by the stone. So how to know the hard stone? Just if the Hounsfield unit is more than 1000, it's a hard stone. And if the patient has a morbid obesity, is very obese, how to know that? CT scan will tell us that the stone to skin distance. If it is more than 10, these all are the contraindications. If you do that, if you do the breaking in these scenario, it can break. The problem is it cannot clear the stone. Okay, that's the problem. And but regarding this one, this is absolute contraindication. Absolute means never do. Pregnancy, obviously, is shockwave. Don't pass the shockwave through the pregnant lady. Urosepsis UTI. If you do a breaking of stone in a urosepsis or UTI, then it can lead to then UTI can lead to urosepsis and death. If the patient don't have a correction of the coagulopathy, then the minor bleeding can be converted to severe bleeding. And aortic aneurysm is a dilatation of the aorta, the fusiform dilatation of the aorta. If the shock wave pass through, it can rupture. So these are the absolute contraindications where we don't do, never do the ESWL. But here, the lower part we do. If we do, then the clearance will be hampered. That's why some are relative contraindication, some are absolute. These are absolute contraindication. Don't do it. Okay. Okay. Just remember the hard stones. Okay. This is important. Commonly asked. PCNL. PCNL means basically the PCNL means puncturing the skin and then breaking the stone. So again, the basic thing is we have to puncture the stone either by a puncture the body either by a ultrasonographic guidance or a fluoroscopy guidance. If the stone is smaller, we can just capture and take it out. If it is larger, then we have to break it into fragments, and the breaking is different here. The breaking inside the body, we can use lot of energy source. Most commonly used energy source are laser or pneumatic. These are very commonly used. Laser is laser, mainly holmium YAG laser is used. Pneumatic means it's a rod-like structure, okay, which is connected to the gas, and this causes the vibration, front and back vibration, and it breaks the stone. It's just like a hammering. If you have seen the construction worker doing breaking the stone, then similarly the this pneumatic rod break the stone. Okay, so this is very cheap and the best one, cost effective, but obviously better one would be laser. So laser and pneumatic are most commonly used. Other source may be ultrasonic probe or electrohydraulic probe. There are other probes, but mainly we use pneumatic and laser more commonly. And after breaking the stone, what we do is we put a DJ stent, and we put a sorry what's happening, yeah, DJ stent, and we put a drain tube. These are the very basic steps. Let us see. First of all, the patient will be lying in a supine or lithotomy position where we can use the cystoscope. See this machine here, you can see this is a flexible cystoscope. You can use a rigid cystoscope as well. So after just putting a cystoscope, what you can do is you see this monitor. So we are inside the bladder. Then now what we are doing is you're putting the uretral stent, okay, stent in the ureter. So this stent is kept up to the kidney, and after putting that stent inside the ureter on the direct vision, now we have to change the position of the patient in a prone position. After changing the position, we do repainting and redraping. After that, what we do is we can puncture the kidney either by using ultrasonographic image, or we can use X-ray fluoroscopy. So I'm showing you the both. See over here, the surgeon has used the this is ultrasonogram probe, and you can see in this hand you can see the needle is there. Okay, So by seeing the image, this is the part where you is trying to puncture. So by seeing the image, uh, you can puncture the kidney. Okay. And even you can use the fluoroscopic technique. Here the dye is pushed from the below, and this is the needle puncturing the lower calyx. Okay. So here is the stone, maybe. Okay. So you see this image after puncture, accurate position is seen by the fluoroscopy. Here, this is the needle exactly at the desired place. After that, we have to dilate the tract serially. Okay, dilate it serially, and we reach to the point that we want to reach. Okay, so how much to dilate depends on what PCNL you are doing. Okay, if you do a standard PCNL, we dilate up to 24 to 30 frames. If you are doing a mini PCNL, then we dilate up to 14 to 20 frames. If you are doing ultra mini PCNL, 11 to 13 frames, then we can dilate according to our need, our instrument. Okay, so we can do that. So we can do a bigger one or smaller one depending on the size of stone and what you want to do. So nowadays very commonly done standard PCNL and mini PCNL. In standard PCNL, we dilate up to 24 to 30 frames, and in mini PCNL we dilate up to 14 to 20 frames. Okay, after dilatation we put a nephroscope. This is a nephroscope. Okay, connected to the screen, and once we go inside, this is the image, this is the picture showing that we're inside. You can see the stone. Okay, after seeing the stone in this picture, you have, this is the pneumatic rod. See the steel rod, and this rod will hammer the stone and break into pieces, and those pieces can be taken out. And after taking out, we can put the nephrostomy tube and also the DJ stent here. Okay, we put that, and this nephrostomy tube is removed before the discharge within 2 to 3 days, and this DJ stent can be removed within 2 to 6 weeks depending on the situation. You can do that. Okay, I have skipped a lot of other steps, the detailed steps. Okay, which is not required for your level. These are some certain basic steps I have told you. Still, it is a very complicated thing, not that easy. But if you remember this much step, then it's fine. So indications: stone, large stone, stagnant stone. If any other procedure fail, ESWL has failed. Okay, we can do that. Contraindication: if it is a patient having a uncorrected coagulopathy, we don't puncture the kidney because there will be a lot of bleeding. Any active UTI not treated, we don't do that because it can cause a urosepsis. Okay, complication, there are a lot of complications that may arise in a PCNL. Let me summarize few. Hemorrhage, obviously, whenever you puncture the parenchyma, it will bleed. But this bleeding, if there is no other abnormality, this will stop. Okay, because once we put a nephrostomy tube, that tube, the kidney will collapse around that tube and it stop bleeding. But if the hemorrhage continues, or if the hemorrhage continue even after the discharge, delayed hemorrhage, then you have to find the cause and treat the patient. Okay, the detail I'm not telling deliberately. Sometime what happen is, when you are puncturing the kidney, what happen is, sometime the kidney is punctured here and punctured through and through, puncturing the calyceal system or the pelvis. So it can happen. So if that is seen, then just put a DJ stent, it will be okay. Sometime the other organ can be punctured. Okay, uh, suppose colon puncture. Colon puncture is not that common, but sometimes the colon lies posteriorly. If you remember the normal anatomy, I'm just showing you the CT scan image. This is the kidney. Okay, stone over here. Normally colon lies anteriorly. Okay, this is, sometime in 1% of cases the colon may lie back of the kidney, known as retrorenal colon. In that case, if you don't see the colon, if you don't do a CT scan, you just did an IVU and you did a puncture by X-ray fluoroscopy. In that case, you can damage the colon while puncturing the kidney. This is a serious, sometimes very serious, patient may die. Okay, or if you think this way, okay, let me draw the anatomy. You may understand. Okay, this is the body of the human being. This is the, this is the chest area. Fine, fine. So we have lungs over here, the pleura and the lung. Okay. So there's a kidney over here. We are planning for the puncture of the kidney. And if we always puncture from the back, okay, if we puncture the kidney below the 11th rib, okay, then pleura is injured. Just injuring a pleura is not a problem. But if a surgeon puncture above the 11th rib, there is a chance of lung damage. So lung damage is possible when the surgeon tries to go above the 11th rib. Okay, and there are the technique to prevent those things, but still if the surgeon try to puncture above the 11th rib, there's higher chance of lung damage. If below, then pleura may be damaged, but it's fine, no problem. Mild some puncturing a pleura is not a problem, but damaging a lung can lead to a lot of complications like hemothorax, pneumothorax, and so on. So it is always advisable puncture below the 11th rib to be safe. RIS, as I've already told you what is RIS means. We use a flexible ureteroscope, go from the urethra to the ureter and reach the kidney, and by using a laser, holmium YAG laser, we break the stone. Breaking the so fine fragment and dust like thing, and putting a DJ stent, just we come out, and the stone will be excreted. Okay, and basically this can be done up to 2 centimeter whenever the ESWL fails, and we can do these things I've already explained. Okay, contraindication, obviously active UTI, we don't do this procedure. So you can see this is the flexible ureteroscope. The surgeon is holding the scope, and it has introduced inside the body. You can see the stone. Okay, this is magnified view, it's not that big, and you can see the laser probe is breaking the stone. See the stone fragments over here. Okay, and see after the later on at the end the dusting, the very fine granules. After that we put a DJ stent and come out, and then this fragment will come out spontaneously. Okay, so let us discuss one case. Okay, 25 years old male presented with the complaint of the pain at the right loin for 3 months. Pain was dull, aching in nature, sometimes severe pain radiating to anterior abdomen and associated with the red color urine. So see the young man is there having a dull pain coming to the anterior abdomen toward the umbilicus. Urine is red, painful. Then I have given you a classical picture of painful hematuria, and other findings were normal. You can see, you can think it's a case of right renal stone. You can think this is a case of upper ureteric stone, or sometimes pyelonephritis as well. Okay, these are some common differential diagnoses you can think about. Okay. And now, how will you investigate? Obviously, I have told you how to investigate. Okay, you nutrient culture. In this case, you have seen multiple pass cell, RBC is plenty, but there is no growth. That means this is not a case of pyelonephritis. It is just an hemorrhage, nothing else. Okay, creatinine was normal, and X-ray QB and ultrasonogram was done. Let us see the image. Okay, this is an X-ray QB. You can see this is the sector level 5, 4, third. So you can see a round radiopaque shadow at the right renal area at the lumbar third vertebra, and in ultrasonogram shows the cortical area is fine. Is okay. Cortex is fine, and there is a echogenic structure producing posterior shadow. This and size, you will know the size. Okay, you will know the size, you can know it. So after this, what to do now? So now you can do further IV or CT scan, what information you want. Okay, here IV is done. So the radiopaque shadow at the lumbar third vertebra correspond to the renal pelvis and the slightly in the calyx. Okay, so size may be around 1.5 to 2 centimeter. Okay, this much. IV cannot say you about the hardness of stone. It is one is it can only be predicted by the CT scan. Okay. So diagnosis would be now right renal stone at the pelvis, treatment, symptomatic control, painkillers, okay, and PCNL RRS can be done because the size is around 1.5 to 2 centimeter. Do RRS, if not then PCNL fine, or mini PCNL you can do mini PCNL same depending on the size. And if not, if you don't have any of these facilities, go for the pyelolithotomy for this case. Okay, you can do that as well. Homework, if you can see, fine. And see, thanks for the this long lecture, and I have used these reference to make my slides. And okay, let us we'll discuss the next time. We'll discuss about the diagnosis and treatment of ureteric stone. Okay, fine. See you next